thousands of people in person, in places where they live, about issues that are relevant to them and their communities. And we're broadcasting all of it live across the country. So why not a round of applause for the hundreds of people who are online right now watching live. You know, the foundation is the legacy of Canada's progressive past, but also the place of Canada's progressive future. It's these moments and these conversations that help shape the policies that will make people's lives better in the future. So tonight we're securely anchored in Tommy Douglas's legacy. We're about to hear from an amazing person on the topic of Medicare at a crossroads, choosing the future of Canada. Before we get started, however, I have a little surprise. I was contacted yesterday, and I found out that there was someone who really wanted to be part of this, and I wanted them to be part of this too, and we made it happen. So this person fights for each and every single one of us every day to ensure that our loved ones are taken care of, that they get the help that they need when they need it. Turns out her family has a long, rich history here in Saskatchewan. Ties all the way back to Tommy Douglas's work in healthcare. She's a dynamic member of the legislature from right here in Regina. I've come to know that she's a big fan of Tommy Douglas herself. So Mira Conway will be coming to stage. She was first elected MLA for Regina Ulfstone Centre in 2020. She is now the Shadow Minister for Health. She serves as Deputy Chair of Private Bills Committee and the Economy Committee. She's a lawyer, a community organizer, a musician, and with deep roots in Saskatchewan, it is my absolute honor and pleasure to welcome to the stage Mira Conway.
It is to be here and bring greetings on behalf of the Saskatchewan NDP, my colleagues, our leader, Carla Beck, and many congratulations on this inaugural Tommy Douglas Lecture, which is happening exactly where it should be, in the birthplace of Medicare. A special welcome to Dr. Catherine Smart, who I understand hails from rural Saskatchewan. She's been a champion of universal health care and worked tirelessly to decolonize healthcare, I understand, and amplify voices that have too long been unheard in our healthcare system. Also special greetings to Professor Greg Marshallton, who has for so many years put both the public and the intellectual in public intellectual. I had a wonderful opportunity to meet with Greg a few weeks ago, or maybe it's months, time is a thing. We're doing this big bold change in healthcare consultation, and I had, the first of what I hope to be many conversations with Greg, and I learned more about his deep roots to this province, including the fact that he spent a stint early in his career as a public defender with Legal Aid Saskatchewan up in northern Saskatchewan, so he immediately earned my respect. I do want to begin my remarks in a proper way by acknowledging the Treaty 4 land that we're on. Embedded within Treaty 4 is the principle often referred to as the medicine chest, a recognition that the health and well-being of all people who live on this land must be protected and sustained. That obligation is reflected under Section 35, of course, of the Constitution Act, which was drafted to protect Indigenous people's right to health, a right that often, too often, rings hollow and is yet to be realized for Indigenous folks across this province and this country. But those words do speak to broader aspirations and obligations we must cherish, a shared responsibility and commitment to one another, to protect our children, to care for the marginalized, the vulnerable, to provide dignity to seniors, regardless of means. And this is really at the heart of the promise of universal health care. Now, since I work in politics, I probably owe you a few words on how I see the politics of health playing out across the province and country. Now, I can feel the president and provost get nervous, but I promise I'll be well behaved. Some imagine the legislature to be an arid desert of partisanship and division, one lacking in the kinds of bold ideas that we're here to celebrate tonight. And some days you would be right, but not always, not always. And I can tell you that while we all can't agree on what battles we should be waging in 2026, there is one thing I can say with certainty, and that is that my colleagues and I believe that this question of universal public health care and the promise that it still holds is something that is very much worth fighting for. That question is not up for debate. And over the past number of months, as part of this Your Care, Your Say, Big Bold Solutions in Healthcare consultation, we have been asking this question: how do we turn things around in Saskatchewan? Well, and indeed across the country in healthcare. Some things are working. There are things to be proud of. No doubt. I was just chatting with Dr. Smart about some of the neat things that were happening in her hometown of Swift Current. But the list of what is not working seems to be growing every day. And the conversations I have, I'm gonna just touch on two of the things that keep coming up. And one of that is people keep bringing it back to privatization. We have seen a steady expansion of privatization across the country in healthcare, but indeed here in Saskatchewan as well. And I think time and time again, privatization is kind of pitched as this innovative solution to a system that is under incredible strain, to a system that is eroding. But I'll ask, and disclaimer: these are just my questions, and these are hotly debated topics, and they're contested. I'll ask: are wait times coming down? Is access improving? Is it easier to find a family doctor? And I think we can all agree that the answer is no. And so I'm continuing to ask myself, well, what would happen if the tens of millions of dollars we see going into this expansion of privatization was going into public healthcare, truly public healthcare, going into the frontline healthcare workers that sustain our system each and every day? Now, this conversation has become even more urgent, maybe with the introduction of Bill 11 in Alberta. Some are worried that this opens the door to two-tier healthcare. It does remove one of the key safeguards of healthcare, which is that doctors are required. They can go out and do private medicine, but they're required to either opt into the public system or the private. And so there are concerns that that safeguard has now been removed. But there's also a concern that it opens up our healthcare system to American private medical insurance companies. And some have pointed out that once they have a foothold, they can expand across Canada. They can rely on free trade agreements, for example. So I think the way that this legislation plays out does have implications for us all, and it's something we need to be talking about. Here in Saskatchewan, and indeed across the country, it is a critical time for public health care. I think we can all agree on that. And too many people wait too long, for surgery, for cancer treatment, for basic care. Too many in rural communities especially can no longer rely on services, and the inequities in Indigenous health are indeed really a national shame. But despite these challenges, we're all here tonight because we care deeply about public health care. We're proud of Medicare. We feel it is at risk, and we're searching for ways to come forward, to move forward together. So how do we do that? Well, I'm hoping that Greg and Catherine can solve that for you tonight, but if you'll permit me, I will leave you with something based on the feedback I've been receiving, because that feedback keeps coming back to another major theme, and that is primary care. And when I say primary care, I mean a broad, expansive definition of primary care that includes a vision of preventative health, one that considers population, questions of public health, one that recognizes that we will never have a healthy population if 1 in 3 kids under 6 live in poverty, as they do in Saskatchewan today. And so I'm going to ask you to entertain the idea that we've never actually fully achieved the dream of universal public health care. Not truly. We have never really built the true system of comprehensive coordinated care led by a team of diverse health professionals, a system rooted in the needs of community, accountable to community. And bear with me, before I wrap up, I want to read to you a quote. "We must now move increasingly toward group practice, whether it's community clinics or cooperative clinics, but the need for group practice so as to make possible the practice of preventative medicine." Can anyone tell me who said that? Tommy Douglas. In 1979, when he was talking about the second stage of Medicare. And I'm not sure we ever got to that second stage, folks. And imagine that our population of folks over 75 will double by 2038. We are not planning for this inevitability, and if you think that the system is struggling now, close your eyes and think about that. The population over 75 will double by 2038. It's sort of terrifying. An ongoing relationship with a primary care team, one that knows you, your history, your family, where teams can play to their strengths, so chronic conditions don't go undiagnosed and untreated, so someone is there in your corner to advocate for you, whether it's to see a specialist, whether it's to get you on social assistance, whether it's to stand up to your landlord, one that connects the dots for you in an increasingly complex system, where your health needs are integrated, not siloed. Do we need to keep building new urgent care centers? I don't know. Maybe these can be integrated into our schools, our nursing homes, our campuses, our daycares, our existing communities. Without primary care options, we resort to walk-in clinics, to urgent care centers, to ERs, and we're now at a point where we're wondering if the canary even has a pulse. And that's why, a primary care team gives you a better life, a longer life, and it's cheaper, and yet we spend a fraction on building out that system. Anyway, I've been enjoying this Big Wolf consultation, can you tell? We promised Big Wolf change. I think we're committed to it, but we need your help and the help of leaders like Greg and like Catherine, and it's conversations like this that are going to get us there. And where better to do it than right here in Saskatchewan, where it all began. And maybe it's time to build the primary care system that Tommy dreamed of. Maybe it's not. Maybe it's something else that we need. But either way, I know that people want solutions. They do. They're ready for big, bold solutions, and they understand in their bones how much is at stake. And as much as we have to be proud of as Saskatchewan people, this much I know. We cannot rest on our laurels anymore. We can't afford to. And maybe tonight is the beginning of a conversation that reaches back into the best parts of our proud legacy, but also pushes us forward towards a new future where we can be leaders once again. So thank you so much. I'm so pleased to be here, and I'm so looking forward to tonight's presentation. So thank you so much.
Really fantastic. I know that Tommy Douglas would be really proud of us gathering together here, but also proud of the work that Mira's colleagues are doing in the legislature. It's really, really very important. So let's jump in. Let's get into this lecture. Canadian Universal Healthcare. I have a question for all of you again. We did this before, we'll do it now again. Who here attaches Canadian identity, your Canadian identity, with universal healthcare? When you tell people you're Canadian, who here feels proud that that is attached to your Canadian identity? Let's see if I find it fascinating. No matter where I go, no matter what the political stripe, everyone's proud of the fact that they're Canadian and we have universal public health care. Which also raises the question, why aren't we fighting harder to protect it and expand it? Saskatchewan is indeed the birthplace of Medicare in Canada, so we're going to delve into the many facets, the many issues that healthcare is facing. It's complicated. It's a wonderful talked about at kitchen tables, across the fences, across the yards, and it's definitely something that people consider when they go to the ballot box. So for the inaugural Tommy Douglas Lecture, we wanted a dynamic speaker. So we searched high and low, and with the help of the university, we are very lucky. We have an insightful, informative, and inspiring speaker for you tonight. It's my pleasure to introduce our inaugural lecturer, Dr. Catherine Smart. Catherine is a pediatrician, a national healthcare leader, and a respected Canadian voice on the future of healthcare. She was born and raised in Swift Current, Saskatchewan, where she developed an early appreciation for the values of community, equity, and public service that shape her work and career today. Dr. Smart is the former president of the Canadian Medical Association, where she led the profession through COVID-19 pandemic and helped shape national dialogue on healthcare sustainability, equity, and system transformation. She practices pediatrics in Whitehorse, Yukon, where she founded and leads Lynx Health, an innovative team-based model of care designed to improve access and outcomes for children and families in northern rural communities. Her clinical work focuses on child development, mental health, and supporting marginalized children and families. Dr. Smart brings both a prairie perspective and a national voice to her work, grounded in the belief that Canada's healthcare system reflects our shared values and our shared responsibility to ensure it remains strong for future generations. Please join me in welcoming Dr. Catherine Smart to our stage.
Good evening, everybody. It's really exciting for me to be here tonight with all of you, and I'm very honored to be the speaker to give the inaugural Tommy Douglas Lecture. Of course, being here back in my home province of Saskatchewan really makes this very special. As all of you heard, I had the privilege of growing up in Swift Current. And one of the things I really remember from my childhood is something both my parents instilled in me, which was that you're always happiest when you're doing something for someone else. And I think that is a sentiment that really exists in communities in the prairies and is a reason why people pull together in tough times. And that message really planted the seeds, and those grew the roots of what I think has really shaped my journey in medicine. My great-grandfather was an adventurer. He came to these lands from England with other settlers who I think had a dream of a better life in this country we now call Canada. And he ranched in an area that's now called the Saskatchewan Landing, a provincial park where my parents still reside to this day. And after crossing the ocean with these settlers, he became the foreman of the 76 Ranch and eventually, after doing that for some years, he then ran cattle to the Yukon during the gold rush. He lost that herd in a snowstorm, which, having now lived in the Yukon for several years, is not totally surprising. And after that happened, he got on a freighter and went to South Africa, where he fought in the Boer War. He then came back to what at that time was the Northwest Territories, is now Saskatchewan, finally got married in his 60s, maybe 70s, it was kind of up for debate within the family, and had my grandfather. So I like to believe that that spirit of adventure passed down through the generations and has underscored many of the incredible opportunities I've had during my career in medicine. But little did I know the adventure that was waiting for me when in February of 2020, I received the phone call that I had just been elected to be president of the Canadian Medical Association. What I wasn't aware of that exact day was that just weeks later, Canada and the world would be thrust into the greatest public health emergency and crisis of our time. I took the helm of the CMA in the second year of the pandemic, right as the vaccinations we had been anticipating for a long time were rolling out, but governments were grappling with public health protections, ideas around vaccine mandates, passports, what to do at that point. And that social cohesion that I think really defined that early stage of the pandemic where we were pulling together was really starting to fragment, and people were separated and polarization was increasing. In my role as CMA president, I had a front row to the strengths and the challenges of our healthcare system. It's people, it's compassion, it's resilience. I had the opportunity, of course, to meet both physicians and other healthcare professionals across the country and see what they were doing to try to make sure that care kept flowing to Canadians. Emergency department physicians, intensive care physicians working double shifts to make sure that people were getting care. Nurses holding iPads up so families could say goodbye to each other when they weren't able to be together. Community clinics pivoting overnight to virtual care to make sure that care kept flowing to their patients. Healthcare workers adapted with breathtaking speed, and they showed extraordinary courage. But what also became clear during that time was something that's been, I think, harder to confront. Our system is far more fragile than most Canadians realized. And what sustained healthcare during COVID was not design, it was the sacrifice of the people working in the system. And when a system depends on altruism and sacrifice to function, it's not sustainable. In June of 2022, I was asked by Evan Solomon on CTV Powerplay what I thought was coming for Canadian healthcare, and whether it was time to touch on what he called the third rail, private care. My answer at the time was quite blunt. I told him, I'm not quite sure what's coming for Canadian healthcare, but what I do know is that I think our system is collapsing. And I chose that word intentionally. When people cannot access basic care in their communities, when emergency department closures become normal, when people are living with pain and disability waiting for surgeries to restore their function, the system is no longer working as it should. When children are waiting 3 years for an autism assessment, or a suicidal teenager is told it's 18 months before you can get counseling, something fundamental has broken. And the language we use when we're talking about this matters. Words like strain or stress soften what Canadians are actually experiencing. The greatest threat to equity in our healthcare system is not reform. It's a system that no longer works. When public systems fail to meet people's needs, disruption is what follows. And we have seen this pattern across many industries. Taxis disrupted by Uber, film photography completely dismantled by digital photography, video stores no longer exist because we have streaming services. So healthcare is not immune to these same forces of disruption. We already see new forms of care emerging to fill the gaps left by our crumbling system. Concierge clinics where you can pay for access, corporate primary care chains, direct-to-consumer digital medicine, and online prescribing services. These services exist because patients can't access the care they need in the public system. And the danger is that kind of disruption fragments equity unless we lead that transformation ourselves. Crises have a way of revealing the truth. They show us not only what is broken, but also what can be possible. Tommy Douglas understood this. COVID left us not with the question about whether or not Medicare is the right idea. The question is whether we have the courage to renew it, to lead the disruption rather than be disrupted by it. What I think is really interesting about Tommy Douglas's story is that his belief in universal healthcare was not abstract. It came from a childhood experience. Tommy had scraped his leg while his family was still living in Scotland, and they then immigrated to Canada and were living in Winnipeg, and his wound wasn't getting better. And in fact, it was getting worse, and the infection spread, became deeper, and actually infected his bone, giving him something called osteomyelitis, which is a very serious and difficult to treat infection. And his parents were told that the surgery that he needed to fix his leg was very specialized and very expensive. And his family didn't have the money to pay for that particular surgery. So the physician caring for Tommy offered his parents the option of having his leg amputated to save his life. So I can only imagine what it would be like as a parent staring at your child who has something treatable, and your option is to remove their leg because you can't afford the procedure that would actually allow them to live their life jumping, playing, running with those other children. But that was what they were facing. But then something happened. Another surgeon came along, a surgeon who had the skill to do the procedure that Tommy actually needed, and he offered to do the operation for free, with one caveat. Tommy and his parents needed to let the medical students that surgeon was training observe the procedure. So They agreed, and they went ahead and he had the procedure, saved his leg, and had a full recovery. But as you can imagine, that experience left a lasting impression. Douglas never forgot that his ability to receive care depended on circumstances beyond his control. He later said that that moment helped him understand something fundamental, that access to care should never depend on luck, charity, or wealth. It should depend on need. And that insight eventually shaped one of the most important social policies in Canadian history. But Tommy Douglas also never believed that Medicare was finished. He understood it as a beginning. He once said, "Courage, my friends. It's never too late to build a better world." Medicare was not simply a policy innovation. It was a moral declaration that people matter equally, that care should be based on need, not wealth, that we are responsible for one another. But Douglas also understood something fundamental. Promises do not sustain themselves. Institutions do not remain strong by inertia. Each generation must choose whether or not to renew them. And that's the choice before us now. The Canadian healthcare system is a little bit like a transformer. We keep rearranging the existing pieces, hoping that if we move them around enough times and in the right way, something fundamentally different will emerge. A new program here, a new funding envelope there, another pilot project on top of one that we already had. But rearranging the pieces does not change what the system was originally built to do. Canada's healthcare system was designed in the 60s for a very different reality. Life expectancy was around 70 years old. Most care revolved around acute illness in hospitals. Mental health, chronic disease, aging, and social complexity were not yet the dominant drivers of health and illness that they are today. Medicare was designed as a universal insurance plan to provide coverage for care by physicians and hospitals. And in that mission, it had succeeded, and it continues to succeed to this day. But insuring hospitals and doctors is not the same thing as building a system that creates health, that supports people living with chronic illness, or meets the needs of increasingly complex things that Canadians are facing today. And that is why so many Canadians experience a gap between what they believe Medicare provides and what they actually encounter when they seek care. Healthcare in Canada is not truly universal. Not when millions of people lack access to primary care, not when mental health care remains inaccessible for many, and not when many Canadians cannot afford the medications that they depend on and need to manage their chronic illnesses. And not when Indigenous communities experience worse outcomes across nearly every measure of health. Universality is not a principle we can just declare. It is one we must continuously build. I think those of us in this room likely share a vision of a country where we have a thriving population, where health is created and sustained over the lifespan, and we shift from an illness system to a true health and social care system while continuing to generate timely access to acute care when people need it. A healthcare system that sees you and treats you as a whole person and allows Canadians from all walks of life to flourish. Right now, Canada spends over $350 billion a year on healthcare. In every province and territory, it is the largest line item in their budgets. Yet outcomes and access have not improved proportionately. In fact, a recent study in BC showed that people are living longer with the lowest quality of life they ever have had. And we know that the vast majority of healthcare dollars are spent in the last weeks of people's lives. We have a rapidly aging population. Many people have chronic diseases. Study after study tells us what aging people want is to be at home. They want to age in place. But that's not what is available to them. Instead, they're in hospitals, they're in long-term care facilities. Home care, what people have asked for and desire, is hard to come by because it's not something that we have invested in or created in a substantial way. We also have to realize that Canada can't fix access to care without fixing the front door of our system. Every high-performing healthcare system in the world is built on universal primary care teams, with teams being the most important word. It's not just physicians, it's nurses, pharmacists, social workers, mental health experts, dietitians, OTs, PTs, working together. And when patients have a continuous relationship with the team, what happens? Hospitalizations drop, people are healthier, and health improves and costs then fall. But in our system, the tyranny of the urgent is preventing the thoughtful renewal Medicare requires for our time. And that gap between what Canadians believe Medicare provides and what they actually experience is widening. So at times it's actually perhaps better described as a chasm. And the real concern is that as that gap grows, trust erodes. And as misinformation continues to grow and spread, trust in science, trust in healthcare professionals, the only real antidote to that has never been more important. So, in my view, to go where we need to go, I think we have to embrace a process of unlearning. A universal, publicly funded healthcare system is a critical part of our Canadian identity and something that I think the vast majority of Canadians want to believe in. But we are not achieving the core values that underpin that social contract, the most important of which is equity. I don't know if you'd be surprised to know that amongst similar countries, Canada ranks at the absolute bottom for equity, just above the United States. We are literally second to last. We have universal public funding, yes, but we actually spend fewer public health dollars, percentage of public health dollars, than many countries that have better systems that are performing better than ours. In fact, only 70% of dollars spent in Canada on healthcare are actually public dollars. 30% of the dollars spent on healthcare are actually private. Glaring omissions from our system are a lack of universal pharmacare and the fact that mental health and social care are not in the basket of universal healthcare. Accessibility is a huge problem and it's getting worse. Right now, about 1 in 4 Canadians, and in some places more, do not have access to primary care. And those who do have access to primary care do not necessarily have real access, meaning yes, they might be assigned a primary care provider, but when they want to see that person, it might be days, weeks, or months until they can get an appointment. And what's concerning about that is we know that the most cost-effective form of healthcare and what's fundamental to better healthcare outcomes is that access to primary care. Treaty. We have failed on our treaty promises to Indigenous Canadians who have the worst health and worst health outcomes in this country, and still experience anti-Indigenous racism throughout our healthcare system that not only re-traumatizes people, but at times has directly cost people their lives. So the result of these failings is predictable. We spend enormous resources treating illness and palliating chronic diseases while underinvesting in preventing them and creating health. We have to understand that equity requires action, not only aspiration. Medicare is important because it represents something much more than a healthcare system. It's not simply a program. It's the way Canadians have decided care should work in a just society. It represents a social contract, a shared agreement between citizens and their country and their government. And that, what do we believe, what is that social contract? That in our times of vulnerability, the care that we need will be there for us. So what do we do? How do we rebuild and make good on this promise? To begin with, we have to seriously think about our operating system. We keep adding the apps, new programs, new funding envelopes, new initiatives, but the operating system itself has never actually been redesigned. But COVID showed us something. It gave us some examples of what it could look like if we decided to upgrade our operating system. What was different in COVID? We had ambition. Vaccinations into the arms of every Canadian who wanted one. That program was rolled out in record time, and we saw unprecedented cooperation between all levels of government to execute it. We pivoted and scaled virtual care almost overnight across the country to make sure that care continued to flow to patients. We decanted data. Groups that had never had access to their data before were given it. Communities were given data so they could make decisions. First Nations groups in Manitoba and the Yukon were actually given community-based public health data so they could make decisions for their community about how to manage the pandemic. And these communities had excellent outcomes. We broke down silos. Hospitals scaled capacity and resources to meet demand when ICUs were overwhelmed, and we actually at times moved patients between provinces to ensure capacity and to ensure that people were able to get that critical care to save their lives. So in that moment, we started to question, what is the value of the regulatory barriers that make physicians have to be licensed in every province and territory? Why does it have to be that way? We learned that we can change, we can do hard things, we can be flexible, we can adapt, we can change the operating system. We have to consider some hard realities as we aspire to transform health and healthcare in this country. Receiving timely healthcare is not a human right in Canada. This is a common misperception. And a recent decision in BC courts affirmed this. What the judge said was that Canadians have a right to a publicly funded system. That is true. But what they do not have is a legal right to receive care within it. Let that sink in. So what we're left with is a state monopoly on healthcare delivery, but with no recourse for citizens when they can't actually access the care. This creates a profound tension. Healthcare defines our national identity. We care about it deeply, as we should. Yet Canadians have no enforceable right to actually access the care, and there is no consequence to governments for not delivering care, except perhaps at the ballot box. And this may be the most profound difference between our system and the much higher performing systems in Europe, many of which offer patient care guarantees and pay for care in their private systems when it's not accessible in a defined amount of time in the public system. The Canada Health Act defines 5 principles: universality, accessibility, portability, comprehensiveness, and public administration. But something critical is lacking: accountability. Accountabilities for outcomes, accountability for access, and accountability for results. We measure how much we spend, but rarely whether Canadians are actually healthier. So much of our healthcare funding is block funding. It's not tied directly to patients or outputs or outcomes. Physicians are largely paid fee for service, which may push volume but doesn't always guarantee quality. Physicians who are sometimes on alternative payment plans aren't necessarily accountable for volume. People working in the same system can often be incentivized in different ways, and this can create teams that are at odds with each other and not always then pulling in the same direction in terms of how they deliver care. We need to be accountable for the care that is delivered and funded by citizens. Without accountability, we will never be able to build a high-performing healthcare system. Data needs to be the nervous system of modern healthcare. In 2026, the fact that many Canadians do not have access to their own medical record should be embarrassing. If we believe in people-centered and person-centered care, we have to decentralize data and information to people so they can act as the CEO of their own health. And transparency has to be another factor in transformation. Data transparency can create accountability that can help the public know if we're making progress. Transparency creates trust. You can't change what you can't measure. I've been in clinical practice now for 25 years, and I have never once received meaningful data to let me know if the quality of care I provide my patients is meeting any metric. It's incredible, really, when you think about that. We're also facing EMRs which are electronic medical records, which hold vast quantities of data that could guide care, decision-making, and systems planning, yet they don't talk to each other. We've just seen the federal government pass legislation about interoperability, making these EMRs talk to each other. And this is essential, but what's going to matter is how is that funded, how is it rolled out, and is it mandatory, or can you opt out of it? A friend of mine who works in this area of EMRs, gave the example of the railroad. When we were building the railroad to connect Canada, was each province deciding whether they were opting in and out and whether you had a segment in your province? No, we recognized if this is going to connect our nation, it has to be continuous. And interoperability of data needs to function like that as well. We have to axe the fax machine. Yes, in 2026, the fax machine is still the primary way to share information between healthcare providers. It's crazy. DoorDash is more sophisticated. They send me a picture of my food when it's at my door. We can't do that in healthcare. One of the most important things is we need to always be asking who isn't in the room when decisions are being made. When we're reimagining health and social care in Canada, whose voices are we privileging and who's not in the conversation at all? First Nations peoples, Métis and Inuit, racialized Canadians, newcomers, youth, people with lived experience. can't create or co-create a system to meet the needs of those who are marginalized without them in the room. What I learned as CMA president is that by far and away, our biggest asset in healthcare and social care is people. The people who work in the system and the people we have the privilege to serve. Canadian healthcare is full of incredible people. We have world-class people in every domain of healthcare delivery. And they are dedicated. They have been holding this system together with blood, sweat, tears, and duct tape for a long time. But our current operating system is chewing people up and spitting them out. We have a human health resource crisis like we've never seen before. Because we've never planned, we've never had a human health resource planning. Canada has half the number of doctors per capita as other countries with highly performing healthcare systems. Nurses are constantly understaffed and strained, and there's nursing shortages everywhere in this country, and I think this is similar in many of the health professions. We need to relentlessly focus on the work environments we are creating and realize that retention of talent has to go beyond just remuneration. We have to create environments where the systems enable us to do the right things just because they work the way they should, where we're not constantly having to go around them to get our patients what they need. We need to be leveraging technology and artificial intelligence to decrease the administrative burden that is on all healthcare professionals and eating up millions of hours of our time that could instead be spent with patients, delivering care, and connecting with people. Because the whole point of healthcare is that human connection and relationship. So, what are some lessons? Part of the problem, I think, in Canada is it's very hard for us to talk about this because we worry about what might happen if we have reform. We worry about this idea of creating a two-tiered system where people with money can pay and people without can't, American-style healthcare. And we should be afraid of that because nobody wants that. And I don't think anyone would argue that that is a good direction to go. But often we get stuck in this very binary debate, public versus private, that lacks nuance or acknowledgement that already 30% of our healthcare is private pay, so we have private healthcare now. It's just not well regulated or integrated into the rest of the system. When you look at high-performing systems in Europe, countries like the Netherlands, Denmark, Germany, and France, you see a different conversation entirely. They are not arguing about ideology. They are actively designing systems around accountability, guarantees, and access. Take the Netherlands, often considered the gold standard for accountability. Patients there have a legal right to timely care. If the public system cannot provide it within the required time frame, the system, not the patient, is responsible for arranging care elsewhere, potentially within the private sector with the private provider, but at no cost to the patient. The burden of the system failure never falls on the patient. The Netherlands also publishes transparent performance data, wait times, outcomes, complication rates, patient satisfaction, so hospitals compete on quality, not on the ability to charge patients and fees. Denmark has taken a similar approach with its national treatment guarantee. If you can't get treatment within 30 days, you can receive care at another public hospital or from a private provider, fully paid for by the public system. In their design, private capacity acts as a pressure release valve, strengthening the public system rather than replacing or competing with it. Germany has a different approach. In their system, they've combined universal coverage with largely private providers, but it's tightly regulated. Prices for publicly insured patients are nationally set, which prevents problems with charging people unlimited fees. The result is a hybrid system where private delivery expands capacity while equity is protected. And in France, private specialists are widely integrated into the public system. Patients are reimbursed, prices are regulated, which allows private providers to increase access without creating inequality. Finally, across much of Europe, especially in Denmark, you see a major investment in home and community care. These countries made a deliberate decision years ago to prioritize aging at home rather than in institutions. And home care is treated as an essential health infrastructure, not as an optional social service like it is here. The most important lesson from all of this is that European countries do not obsess over public versus private. They have both, as do we. They focus on whether the system guarantees access, measures performance, and invests upstream in community care. Canada, we have that foundation. We have a foundation of universal public financing, but we do these other critical things poorly, and that is why our system is not performing as it should. We lack the accountability mechanisms and the guarantees that ensure the actual promise of Medicare, which is this idea of equity in access and equity of outcomes. We lack that, so it doesn't actually get delivered to patients as it should. And that is where our next phase of reform must focus. Patients don't necessarily experience healthcare as public or private. They experience it as accessible to them or not. And as long as it remains inaccessible as it is now, it will continue to be disrupted, and perhaps not in the way we want it to be. So fundamentally, I believe we have to ask ourselves the question of what we are trying to achieve in our system and whether our resource allocation reflects that. Right now, we have a system where it allows people to fall off the cliff, and then we spend all sorts of money trying to find them at the bottom of the cliff and bring them back to health. We need ambition, investments, and resource allocation reorientated to the community where health can actually be created and sustained. No healthcare system, no matter how well designed, can treat its way out of a chronically unhealthy society. Universal basic income, housing, food, clean water, these should be available to every person living in Canada. It's shocking to me to think there's children living in communities in Canada where they cannot drink water from the tap in their community. This would never be acceptable in downtown Toronto or downtown Vancouver, yet it happens every day. We know, and I certainly deeply believe in this as a pediatrician, that the life trajectory of physical and mental health is created in the first 5 years of life. And interestingly, the majority of chronic illness actually has its roots in adverse childhood experiences. Prevention of disease and creation of well-being is the only way to address the demand side of healthcare in a way that our supply limitations may actually be able to meet. So we've come back to this idea of whole, a whole of government approach, a whole person approach, a whole lifespan approach. But I also want us to reflect that these are not new ideas. The original people of these lands knew this. They knew that the way to be whole, healthy, and to thrive was through relational accountability and a view to the 7 generations. Many of the answers we are seeking have long existed in Indigenous ways of knowing and being. And as we look towards achieving truth and reconciliation, we may find that many of the answers that we should be looking for and where to place our ambitions already exist. Tommy Douglas once said that his belief in Medicare began when he was a young boy whose family could not afford the surgery to save his leg. Those experiences taught him something profound, that access to care should never depend on wealth, luck, or circumstance. It should depend on need. Douglas did not build Medicare because it was an easy thing to do. He built it because he believed Canadians deserved better. Medicare is not simply a healthcare system, it is a promise rooted in compassion, a promise rooted in justice, a promise rooted in the belief that we are stronger together, caring for each other. But promises do not sustain themselves. Each generation must decide whether it will renew them. If we fail to renew Medicare, the system will not simply remain as it is. It will continue to be fragmented. It will continue to be disrupted. The commitment to equity that Canadians value so deeply will continue to erode. So that crossroads is here. The first phase of Medicare was about protecting Canadians from financial catastrophe by allowing them to be covered for care from physicians and care in hospitals. The next phase must be about guaranteeing timely access to care and creating health across the lifespan. If Medicare is to survive this next chapter, 3 things must change. We must guarantee access. We must measure and be accountable for outcomes. And we must invest in the conditions that create health in the first place. The question to me is not whether or not Canada can afford to renew Medicare. The question is whether we as citizens have the courage to build the country that Tommy Douglas imagined for us. Thank you.
Fantastic. Thank you so much, Dr. Smart. Those 3 points at the end bring it all together. Accessibility, accountability, and investment. And I think that all of us can agree. Let's give another round of applause. I think that... program for tonight. Now, when you bring somebody as accomplished and as fantastic as Dr. Catherine Smart to the stage, you need to pair that person with someone equal, or at least close to. And so we tried really hard. What this next person, our host moderator, didn't know, last year, he launched a book called Tommy Douglas and the Quest for Canadian Medicare. We launched an event with him at Carleton University a little over a year ago. What he didn't know is when we were doing that, I already had him in mind to be on our stage here tonight. I think it's kind of funny. Anyway, I have the privilege of calling this person my friend, but he's so much more. And all of you already know him, or many of you, anyway, already know him because of his extensive work in the province. But I now have the challenge of reading this biography. When you become so accomplished, your biography grows, and it wouldn't be just if I didn't do him the service. Gregory Marshall is Professor Emeritus, Institute of Health Policy, Management, and Evaluation at the University of Toronto, my home university, and founding director of the North American Observatory on Health Systems and Policies. A scholar practitioner, he has extensive experience in establishing and working in national and international research and policy networks. His research primarily focuses on the history of public policy, with a particular emphasis on comparative health systems and policies and universal health coverage. Greg has worked in 3 professions over his lifetime: as a lawyer, as an academic, and as a professor. Also, his pretty helpful stint in the public service, where he served as Deputy Minister of Intergovernmental Affairs and Deputy Minister to the Premier and Cabinet Secretary of the Province of Saskatchewan, as well as Executive Director of the National Commission on the Future of Healthcare in Canada. He has also done consulting for governments and international organizations on cabinet systems, on decision-making, public policy, capacity building, and health system restructuring. Greg is a member of the Order of Canada and a fellow of the Canadian Academy of Health Sciences. In recognition of his contributions, he is awarded the Charles Taylor Prize for Excellence in Policy Research in 2022. Please join me in welcoming our host moderator, our friend, Greg Marshall.
Well, Catherine, thank you so much for the wonderful exposition. And I want to, if I can, just dive down a little bit deeper. I'm going to start with your title, Crossroads of Medicare. And the reason I want to start with that is because that was also the exact phrase that Tommy Douglas used in 1980, and Monique Bégin used it as well. And it, in fact, was the reason that we have the Canada Health Act as a consequence of concerns at that time. Then let's go forward to 2002. That was exactly the phrase that Roy Romano used when he issued his report for the Royal Commission on Future Healthcare in Canada in calling for major transformational change in the country. Now, you've used the phrase too, but in your exposition, what I hear is that we are at a more dangerous period in our history, a more difficult phase perhaps, than what Roy Romano identified, or even what Tommy Douglas and Monique Béjean defined in 1980. Is that accurate? And if so, tell us why.
I think it is accurate. And I think what's different is I think along the journey of Medicare, there's been lots of conversations, understandably, about expanding care. How do we expand the basket? How do we make it more sustainable? But when we were having those conversations in the time when we talked about, I don't think we had quite the same crisis of access and actual care delivery that we have now. Yes, there's been challenges along the way, but it is declining very rapidly. And I think that's something, where the pandemic really sort of pushed a lot of people over the edge and really pushed the healthcare system to the brink. And I think what's happening now is we are seeing the system being disrupted, as we talked about, in different ways, and I think that's creating different threats. We're seeing all these different ways of providing care sort of merging and sneaking through the cracks, and these are things that can undermine having a healthcare system that's actually equitable and reaching people, and I think that's a real concern. And I do feel like the systems around us are really at the strain, and this is my worry, and as I mentioned, why I used that word collapsing in the interview, is I can see that's what was happening. And I think what's really worrisome is that we are, I think, as Canadians, almost becoming too accepting and complacent of the situation. I'm often surprised that people are on the streets protesting. We should be much more angry than we are, and I think that's, Canadians are known for being polite, and that's wonderful, but on this topic, I think we have to really get a lot more serious in what we're demanding. And I think there's so many conflicting things going on in our world, it's complicated, and these things and because we have this sense of, well, at least it's not American healthcare, I think, one of our biggest problems is being neighbors with the United States, because people in their minds just think there's what we have and there's what they have, but there's all these other countries doing it much better, and that's what we should be aspiring to. So I do really worry where we're going. Rise and spread awareness and disinformation, the fragmentation of care, the burgeoning of these kind of private things that are coming into the cracks, but not in a way that's actually improving our healthcare system and what that means for us. And I do think that access is perhaps worse it's ever been, and that is concerning. And with an aging population, it's even more concerning. So I think there's a lot of things happening right now that are really threatening fundamentally whether or not when you need care for yourself or your loved one, will it be there for you? And we should, as citizens, I think, really be rising up and taking this very seriously, because there is a better way to do it, and it's not what we're doing.
Okay, well, Medicare is often defined as sort of dealing with the financial barriers in terms of accessing care. And let's just talk about primary care, because that's definitely within the Medicare basket. And assuming that there is an access crisis, and there definitely is in parts of the country, how best to deal with that when talking about primary care? Because we've been trying to deal with this for years in many ways, and I was just sitting beside a person, Louise Simard, who was Minister of Health in the early 1990s. She introduced wellness and health regions to provide that more holistic care that you're talking about. There have been other attempts in the country. We've been at this for a long time, but we haven't really made the kind of progress that we need to make. So what would you recommend that we do now that will really change this trajectory in an important way?
I think that's an important question, and I think, the piece that we have never had in Canada is a guarantee around your ability to access care. That has never existed. The government has never said, we guarantee your access, it is your right to get this, and there's some consequence if you don't allow it. So we've never set that standard to achieve, and because of that, when we continue to fail, nothing changes. So I think that is one thing that we could do, and what's interesting is some of the European countries I touched on actually put that guarantee in place before they had the system designed to know that they'd be able to achieve it, but that's what drove them towards those solutions. So I think that's one thing we need to do. I think the other piece is, and we talk about this, but we haven't fully embraced it, is really team-based care. It's very clear we do not have enough physicians in Canada for everybody to have a family doctor in, one-on-one situation. We need to be working in teams. We need to be leveraging the skills of physicians and nurse practitioners by having them work with other healthcare professionals in order to be able to reach and serve more people. This idea of like a private practice where you're one doctor with a panel of patients, that is not scalable to the whole country. We just do not have the people power for that. So I think we need to get a lot more serious about team-based care and embracing that. And I think, again, that's one of the challenges of our system design. We have a publicly funded system that's largely privately delivered by physicians in private practice, who again then aren't necessarily part of a system that's designed in a cohesive way to serve their community. So some of these structural pieces really get in the way. One idea that I think people started talking about, which I think is somewhat inspiring and helpful, is this idea that how primary care should be like public schools, right? And Jane Philpott's talking about this, that working on this in Ontario. But what I like about that conceptualization is it's something everybody can relate to. Like when you move to a community, you have an expectation that there will be a school that your child will go to. But you don't expect that the teacher is going to build the school and, provide the toilet paper and, make the books. You expect that the school is going to be there, the teacher's going to be in there teaching, and the other people that are involved, and that your child will be able to go there. And I think that gives, people something to imagine. Shouldn't healthcare be like that too? Like when you move into a community, shouldn't there be a community health center that you can go to with your family? And shouldn't the people working in there be working together to serve your family? And should those people necessarily be responsible for the bricks and mortar, what that looks like? Or should that be something that's part of every community, and the healthcare professionals working in there, their job is to actually take care of you? So I think, there's some of these ideas that help, I think, us crystallize what we should be expecting. But I think we have to be ready to have some hard conversations about what that looks like. But fundamentally, I think we have to aspire to more. And as citizens, we have to demand these things. We have to say, access needs to be a guarantee. It can't just be something that we talk about.
When it comes to primary care, then what you're really talking about is a clinic kind of infrastructure across the country. But you've had a lot of experience with this. You've been head of the Yukon Medical Association, then the Canadian Medical Association. You know that the members of these associations at times have been very opposed to the idea of community clinic system or another system in which doctors are operating and providing primary care services through capitation or something other than fee-for-service. So how do you deal with your own colleagues on this?
This is a good question. Difficult one. Medicine is like any profession. Not everybody thinks the same thing or has the same perspective on what they should be doing or what they want to do. That's just the reality of it. And I absolutely agree. I think the vast majority of physicians care deeply about their work, care deeply about patients and the quality of care they provide, and want to do a good job. But physicians also have things that matter to them too, things like autonomy, not wanting to necessarily be in a way where they're being told how to practice. So I think there's some balance to be found there. But I do think that, physicians need to be part of the solution, and I think it would be untrue to say that they always have been. Sometimes physicians have been part of it, sometimes they've been in the way of it. And I think that's work that we need to do, but I don't think that needs to stop us. I think there are enough physicians that care about this, that want this. The other thing I would say is that it's very clear that the younger generation of physicians coming up want to work in different ways. They don't want to be small business owners. They don't want to work like that. They want to be on teams. They want to work together. They're being trained that way, and they want those opportunities. And often that's what's challenging, is that when they come out of their training in family medicine, those opportunities aren't always there for them. So I think if we start building in that direction, people will come along. I think what people want, the way they want to work, is changing, and I think that is the direction that people want to take. And I don't think we need to let certain people that are in entrenched in an old way of doing things prevent us from aspiring to something better.
Let me ask a slightly different question. Go back to Tommy Douglas, because he really saw the next stage as Medicare in two ways. One, an expansion of the basket of services. He wanted home care, he wanted long-term care, he wanted prescription drugs, eventually included. He knew it would have to be in phases. He was deeply disappointed in the last 10 years of his life to see that we weren't moving in that direction. And as he said in his famous speech in 1979, the second stage also needed to take illness prevention, wellness into consideration, health promotion, the early concepts of the determinants of health. We put all of that out there. And so we were supposed to move on two fronts simultaneously. Looking at it today, what front would you move on first if you had to set priorities, and how would you do it?
Yeah, that's a great question. I agree. I think Tommy Douglas really was visionary in that way of understanding what it was going to take to have a truly functioning healthcare system, right? And I think that differentiation is important. What we really have is a universal insurance system that covers hospitals and physicians. That is not the same thing as having a universal public health system. So, I think when we're looking at the things that we're talking about, I think to me, we really need to be looking at more investments in prevention and creating health across the lifespan. I think those are fundamental places where we need to be investing, because we have a population that is increasingly unhealthy, and you can't spend your way out of an unhealthy population like I was talking about before. Canada is one of the only OECD countries that doesn't have a national children's strategy. We are, again, ranking near the bottom in terms of child health and child outcomes in this country. So I think we need to be looking at what does it take to invest in communities, to make communities healthier, to support families, to prevent adversity, to lift people out of poverty, because these things then create health. So I think that's a place that we really need to be thinking. I mean, all of these things are areas that are important. I'm probably also biased because I'm a pediatrician, but I really do think we need to be looking seriously about what are we doing to create a healthier country. What does that nation building look like? And that really starts by supporting children and their families to be healthy.
Now I'll switch to something a little different, which is you put a lot of emphasis on accountability, and I remember in 2002 in the Romano report the issue of adding accountability to the current 5 principles under the Canada Health Act, that it should become the 6th. I'd like to know what you think about accountability in terms of who should be accountable to whom, for what, and what would be the enforcement mechanisms. Should it be through the Canada Health Act? And you mentioned the block transfer, which is the Canada Health Transfer. Is that part of the accountability conundrum? I think you suggested it was. So how do we go about fixing that accountability? And here we've talked a lot about some of the federal mechanisms, but you can talk about some of the mechanisms at the provincial level, because after all, most of the healthcare delivery decisions are really made by provincial governments in this country.
Absolutely. And that is, of course, one of our challenges, right? Is we have a model where the federal government is a large funder, but the actual delivery of healthcare happens provincially. And we have that challenge that these large healthcare transfers happen, but historically have not happened really with any accountability. And in fact, there's lots of cases where the provinces haven't even necessarily spent the money that was given to them for healthcare on healthcare. And some provinces haven't even spent all of the money that they were given on delivering healthcare. So I think it's, when you really think about it, like, it's quite shocking to think that this level of money is out there with no clear accountability. I mean, where else in the world or in our lives would something like this make any sense? Like, we're talking about billions of dollars, and like, oh, I hope you did something with it. Like, it's actually quite crazy. And again, in my mind, is something that this is our money, this is our tax dollars. We need to be talking about this more vigorously. So I think we need accountability all the way through. You know, you asked me earlier about physicians. We need to be accountable for the care we provide, how we're organizing ourselves, what our relationships look like, and whether we're part of building a better system. That's one level of accountability, right? The provinces need to be accountable to their citizens in terms of the programs they're delivering, and in my view, that accountability, like I've touched on, needs to say we guarantee that we will have access to care, and there's going to be some outcomes, some responsibility if that doesn't happen. There needs to be accountability between the provinces and the federal government. You know, I think it's really surprising that the federal government continues to issue billions of dollars in health transfers without really expecting anything in return. And, I mean, these are obviously challenging conversations politically, because understandably, you know, the provinces and territories don't necessarily want to be told what to do. But when you're spending billions of dollars on something that is declining and not working, at some point, someone has to say, enough is enough. And that's why I worry. I worry when the conversation centers on always more money, because my concern is we continue to spend more money in a system that's fundamentally poorly designed, lacks guaranteed access, lacks any accountability mechanisms. What are we going to get for that investment? And we should care about that, because when it's not working, it impacts your ability to get health care when you need it. So, you know, I think we need to build in accountability literally at every level, and I think part of accountability is transparency. As citizens, we should be able to look and see what is happening with these dollars. I mean, again, it is the modern times. How is there not a website that just shows you everything that's going on, where you can look and check and understand these things for yourself? But that information is not there. So I really feel that accountability needs to underpin everything that we do. It needs to be transparent to citizens. We all need to understand what's happening when. We need to know what we're headed for, what the goals are, where we are on the road to achieving them. And I think, you know, right now, the other challenge is often the federal government, you know, it acts a little bit more as it's coming kind of down on people for what they're doing that they're not supposed to be doing, rather than incentivizing the behavior they want, right? So there's a lot of, oh, if you do that, we'll take money away, if you can't do that, we'll take money away. But where is this idea of we will give you money if you do things in the right way? Let's incentivize the things we want and reward those. So yes, you get this pocket money if you make things interoperable. You get this pocket of money if you actually create primary access for everybody in your province. You know, and these things could be linked to the things that we want to see being achieved, but right now, that's not how it works. So I think there's huge room for improvement there, and I literally think it starts from the basic doctor-patient relationship all the way up to the dynamic between the federal and provincial and territorial governments.
That's right. I think one of the important things though that you mentioned is this is accountability not just between governments. And our legislation, the Canada Health Act included, is really a relationship among governments.
Yes.
And what we need to do is transform it into a relationship between governments and their citizens, between provincial governments, the residents of that province and territory, between the federal government and all Canadian citizens. And there needs to be this transparency and reporting needs to occur, so that if there is a breach of the Canada Health Act, that people in a particular province can actually see that, it's evident to them, and that they're allowed some recourse, not just the government, but the citizens of that province. That's very important.
One of the real fatal flaws of our system, and why it's declining to the degree it has, is that fact that when you can't access healthcare, nothing happens, right? You know, to me, this is one of the key differences in your, you know, as I said in my lecture, when the system is not working in Europe, it's not, that burden of that system's failure is not put on the patient. It's put on the government to remedy it. It's the exact opposite here. When you can't get care, it's on you to have to try to find some way to get it for yourself. No one's actually doing anything about it. You know, when you're told, you know, I'm sorry, you can't walk and you're in severe pain and you can't work, but it's 3 years to get a new knee, what are you supposed to do? You're like, okay. you know, like we don't have any recourse as citizens. And to me, that is just unacceptable, and I think that fundamentally has to be different.
That's right, and I think that on that though, that civil society is extremely important in terms of providing pressure
Yes.
up to governments. And we have among the most, I think, placid and, in a sense, the quietest patient advocacy groups in the country compared to other countries. And so that's an area that can certainly change. But then think about this from leadership, top down as well. And let's talk about Tommy Douglas in that respect. I mean, for almost a half a century, he exercised leadership in very different roles over that 40 to 50 years on Medicare, both in terms of its establishment provincially, its establishment federally, and its development virtually up to the Canada Health Act. You have exercised leadership positions, both at UConn and in the Canadian Medical Association, and I know from experience how difficult it is to be the leader of that organization. So I'd like you to think about leadership in terms of that high-level political leadership, not just from government, but from organizations as well. Do we have the requisite leadership in your mind to really get us onto a new trajectory, to really renovate Medicare and fulfill its promise?
Yes, well, I mean, I think the answer is we have not had that, because if we had, we wouldn't have this problem, right? So the problem has not been solved by the way we've been doing things, that we know. And if anything, and I think this is the concerning thing, is it seems to be getting worse. So I do think a lack of leadership, a lack of a champion, like Tommy Douglas was, is one of our challenges. And I think, you know, what's so hard, and we talk about this a lot when we're thinking about healthcare, is, you know, it's the way healthcare has been politicized in Canada. For politicians, it's sort of like this hot potato that they don't want to go near, right? Because it's like, for them, I think a bit of like a middleman type of political issue. You're not going to solve the problem in the time you're in government. The timeline's too short. If you start, you know, trying to make sweeping changes, you're not necessarily going to realize them in your electoral cycle. So how desirable is that for you as a politician? Because obviously, a major part of your job is getting reelected. So having the courage to sort of be willing to take that on, knowing that you may not get to the end of it and not knowing what might happen if your government changes, I think has led a lot of politicians to back off. I think we also have the challenge of the time that we live in with social media sound bites. It's hard to have these complex conversations on TikTok or on Instagram or on Facebook or in these brief media clips. You know, and as someone who did a lot of media, you get asked these questions, but you literally have seconds to answer. It's really hard to have a conversation like we're having tonight where you really want to get into the complexity of it when there's not those opportunities necessarily to have those conversations. So by no means, you know, I appreciate why it's difficult for politicians. But at the same rate, I think when we find ourselves in this time that we're in right now, when so many things about global norms and things are shifting rapidly, and we are talking about protecting our sovereignty, we're talking about nation building. How can we achieve that if we don't have a healthy population? How can we achieve that when Canadians are suffering and not able to meet their full potential because they aren't healthy and the healthcare system's not working? This is a fundamental piece of that. So I think we absolutely need political leadership, but I think like any big nation building process, it really has to come from the citizens. And I think what we know is at this point in time, we haven't had politicians that are really willing to take this on voraciously. So I think it's really time that we need to create a social movement around this that swells from the ground up, right? As citizens, we need to educate ourselves about what our system is and isn't. We need to be able to have informed conversations. We need to not be afraid of reform, because I think this is the other problem, because we're afraid that change might mean American-style healthcare, we become passive about it because we're fearful. But we needn't be that, right? When we band together with clear ideas about what it is that we want and deserve, I think we can start influencing these changes. But I do think, you know, am I confident that there's someone sort of at the higher up level that's going to take this on and see this through? I'm not so sure, but I do think that as citizens, we can form a social movement. We can partner with these different groups, and we can lead.
Well, on that optimistic note, I'd like to ask if anybody would like to ask a couple of questions. I think we have time for a couple of questions, Josh, at least. And you can direct them to Catherine or to me, but I prefer you to direct them to Catherine.
Probably heard enough.
Yes, go ahead.
Oh, there's a microphone. There you go.
In the spirit of the microphone, so the need, God does not change the condition of people and didn't change what is this. So thanks for pointing that out. That's really important. It will never change as a community, as a society, as a country, especially. We change it. They don't overall. Then start timing with it.
Who's in the room when we're creating systems? Whose voices are we listening to? And I think we, you know, it's imperfect for sure, but I do think we're starting to realize that these power dynamics are important, and these conversations need to involve all the people that are impacted, right? And we need to have different voices in the room, and we need to particularly be looking to people who the current system is not serving. And those are people that we need to be talking to about what does the system need to look like to work for you. So I think that this is an important part of reimagining healthcare. I think we have to acknowledge harms. I think we have to acknowledge that there is anti-Indigenous specific racism in our healthcare systems everywhere, and it's real, and it is dangerous, and it kills people. And we have to be willing to own that and really interrogate what's going on there. And I think, how do those things change? I think some of it is representation. We need to have more diversity in who our healthcare professionals are. People need to, every young child, whatever background they're from, needs to be able to look and see themselves in every healthcare profession, right? They need to be able to dream and aspire to being that themselves. And I think when we start to have that diversity, we are going to have better systems. But if the system's dominated by one type of person, one gender, one race, one way of thinking, we're never going to come to solutions that work for everybody. And I think we're getting better at that, but it's baby steps, right? It's still lots of examples of where we're not doing a good job, but I think there's more awareness. I think it's changing, and I'm optimistic that those shifts will bring about a better healthcare system for everyone.
No, might need a bit of help here. Yes.
I'm interested in this question of accountability. So if I go and my doctor says I need a treatment, and I go and the accountability is I should have that in 90 days, 6 months, whatever it is, and that doesn't happen, then someone else is going to come show up to replace my hip for me. So where is that orthopedic surgeon going to come from that the government's not going to pay outside the system?
Well, I'm glad you picked orthopedics because they are probably the most underemployed physicians in the country. But what I mean, this is a great example, right? Many orthopedic surgeons don't have access to OR time, and in fact, if you want to pick an area right now where people are trained and then can't work in our system, that is one of them. There are many Canadian-trained, highly trained orthopedic surgeons, often who have 1-2 years of fellowship training, so they're very specialized, who can't find OR time in Canada. They literally can't find a job. So while you're waiting for your 3 years, there's these folks that could help you that actually can't operate on you because there's no OR time for them to operate in, right? So these are the things about our system that aren't working that we need to come to understand. And by no means do I think, this idea of accountability is a simple one that just all of a sudden tomorrow fixes everything. But I think we have to start thinking about some of these things, putting some of these things in place so we have something to aspire to. And we need to understand, like, how does that make any sense that we have these highly trained people who can't get into an OR, or maybe have one OR day a week that they're able to operate in, right? Why are our ORs closing at 3 p.m. in the afternoon and we're not utilizing these after hours, weekends? Some of our most expensive resources are actually very underutilized. So what are we going to do about that? So there's lots of things I think that could be changed and shifted where we could be doing better, but I think it has to start with this idea that we actually are accountable to you. If you need something, that we need to be able to deliver it, and then we need to look at what to do
Isn't
and how to
that
go
the
away.
same problem with the accountability orthopedic surgeon needs an OR? So why don't we just fund the OR properly to put the people we have to work to meet the needs that we have? Why do we need an alternate fee system?
Well, I'm not suggesting that we need an alternate fee system, just to be clear. I wanted to present some ideas about how other places are doing it, and by no means am I saying that's necessarily what we should be doing, but rather present this idea that there's not just one way for this to be. And I think sometimes our fear of I think there's two things, like I said. First of all, I don't think we acknowledge the amount of private care that already exists, but it doesn't exist in a way that's integrated with our system of improves care, so that's a problem. And by no means do I necessarily, or even think that we should be creating a parallel healthcare system in any way. But I think what we need to realize as Canadians is the two options for healthcare are not what we have and what they have in the United States. There's many other options that are working much better, so we should be able to aspire to that without fearing that change means now we have this two-tiered healthcare system like what they have in the United States. And I think it's that fear that we have that prevents us from having conversations about what different could look like. And some of that may be things like exactly the question you're asking. Why do we fund our RRs that way? What are we doing? Why are we doing it that way? What does it look like? I mean, we have a lot of human health resource limitations too that are factors. But I think we need to be able to have these conversations and really dig in about why we're making the decisions we're making and what could be possible. And that certainly doesn't mean that needs to be a whole other system, but the way we're executing within the system we have is clearly not working.
Well,
Do you want to add
I
something?
would love to, but I think that we're getting short in time, and I want to give one more person an opportunity to ask a question. And if you can be very quick in asking the question and the response, I might be able to have time to respond to that.
Based on your speculation, how long do you think this diversity will take place?
Could you say that again?
I said, based on your speculation, how long do you think diversity in terms of having indigenous people in power and be able to at least have a say in what is happening in the country? How long do you think
How long?
diversity will take place?
How long will it be until we start to see that? Well, I think it's already shifting substantially. We are seeing a lot, like if you're speaking specifically about Indigenous people, there are a lot more people training in healthcare. We're starting to see a lot more Indigenous leadership. The president of the Canadian Medical Association that followed me was Indigenous, the first Indigenous president. And we're seeing a lot more funding and support to train people. So I think it is starting to shift. Now, of course, what's challenging is, like anything, there's a hierarchy. So we have a lot of people coming in at the beginning, not necessarily a lot of people, not necessarily in leadership, and that I think takes longer. But I think the first step is getting people in that front door and getting them into the healthcare system so we can start to see those changes, and that is happening now. And I think it's getting better, and we have a lot of really impressive, incredible Indigenous physician leaders in this country that are doing a great job of paving the way and making it better for people that are following in their footsteps.
Yes, I'll just return to the question of the orthopedic surgery, which I know is just an example, but this is an area of elective surgeries that we see that's highly problematic in certain provinces. And part of that is poor management of resources, including human resources, because there's a lot more in a surgery room than a surgeon, of course. It requires a whole team of people. And that is the reason that some surgeons don't get enough operating room time, and it creates long wait lists in provinces. And one of the great advantages that we have as a federation is that there are 10 provinces and 3 territories. And a care guarantee could say that person, if the wait is any longer than 4 months or 5 months, would have to be sent at that province's expense to another province, where a public system could be well functioning. Now, I'm talking about public financing, because almost every physician is a private contractor within that world, but it could be within the confines of a public hospital. And they have to pay double what a normal Medicare patient would get paid in that province, so that there's an incentive to bring in that person, because they're properly managing their wait times. So we have a real opportunity for that. In Europe, it's different because of the European community. They go to a different country often with quite a different system. And it's done there, and sometimes it's public, sometimes it's private. But the commonality is that very high payment. And it's a penalty to the government in question, and they want to avoid it, but they also want to avoid the publicity that attaches to that. And invariably there is some publicity. So on both counts, I think it would be very useful to use our federation in a creative way in that way. But
I think I agree. I mean, what we're talking about, right, is incentivizing the performance we want to see
that's right.
and creating positive incentives when you're doing a good job, and then that allows everyone to sort of rise. And right now, that's not often how it works. Some hospitals do great work, but others are not, and it's, nothing really happens if you're in the or not group.
And the state of knowledge of understanding how some provinces and some health regions or provincial health regions manage those wait times and their systems.
Yes.
And we used to have an organization called the Health Council of Canada that was beginning to look at some of those issues and compare provinces, but some provinces, some provincial governments didn't like it, and then the Harper government basically dropped the funding for it, and it failed. And it's the reason that I actually set up the North American Observatory in Health Systems and Policies, because I realized if we allow governments to do this and it embarrasses them, invariably they will withdraw the funding. So this has to be done in a non-governmental way, and the funding sources will have to be very different. But then you can get out and you can explain how it works in one place, you can compare it to another place, and you can look at who's high performing and who is low performing in all kinds of areas. And the North American Observatory ended up doing, at this point, it's close to 50 reports on precisely these issues. It should be much bigger. We should have an organization that would be capable of having many more resources and able to disseminate publicly to the citizens of this country about performance across provinces. We're not taking advantage of this federation in the way that we should be, because we have 13 different systems.
Yeah, absolutely.
And that offers some real opportunities for learning.
I agree.
Well, I think on that I'll ask Josh to bring the evening to a close.
I just want to say thank you. Let's say thank you